In today's episode, we're going to talk about HRT and blood work. I'm Dr. Valorie Davidson from Progress Your Health.
And I'm Dr. Maki from Progress Your Health. Beginning of the year, 2025, we got some blood work done, and we're going to share.
We're going to talk about it.
Yeah, we're going to share some of our numbers on here. We haven't done blood work in a little while, but to be honest, overall, looking at your numbers, what would you say? Just the overall opinion.
Both of them were good. They're good. We get a lot of questions from listeners and patients and everything about what kind of blood work can I order for my hormones. So that's why we thought we would talk about that, but maybe make it a little bit more personable because we have our own blood work to share.
Sorry, I was adjusting my seat. Like I felt like I was really a little too high and now a little too low. Now that feels all right.
You're just right.
That feels all right. So why don't we do, just because this is a woman-centric YouTube channel, podcast, why don't we go over yours first and then we'll just kind of interject mine. And we'll kind of go, we'll do mainly yours, but we'll kind of go back and forth with mine and yours. Because there's some things that are different on mine and what those numbers mean compared to what obviously you know that. But for everyone listening, yours are interesting, right? We do these numbers all the time. So where do you want to start? You want to start with just a typical CBC?
Yeah, because we did kind of the foundational health, and then we did the hormones on there, because anytime you're going to be treating someone for HRT or taking hormones, you also want to make sure their foundational health is good. So let's go over some of the basics.
Yeah. Foundational. So, making sure metabolically speaking, things are in a good spot, right? That's always a little bit nervous to make sure those numbers are good, especially you and I are now in our early 50s. That stuff becomes more and more important as time goes on. So, everyone has lab work done usually at least once or twice a year. So the first two we're going to talk about is a CBC, complete blood count. Second one is a comprehensive metabolic panel. So anything show up on your CBC?
Nope. So on a CBC, you have the total white blood cells. So that looks at all the white blood cells, and then you break those up into platelets, neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So it gives you kind of the whole packet there. So I love to look at that because that tells us a little bit about the immune system. If somebody, like for example, the eosinophils have to do with allergies. My eosinophils actually were at 4%. Anytime I see them around 4%, usually means there's maybe a little bit of some seasonal allergies going on or something.
I didn't know that.
Maybe dietary.
Allergies, yeah.
I mean, if they were higher up there at 8 or 10, that'd be a whole nother story. But seeing it at 4 for me tells me that there's probably something maybe dietarily or outdoors that might be bothering my system, but not a lot, because my total white blood cells at 5.9 that's just perfect. I'd like to, they have these huge reference ranges, 3.5 to almost 11, right around 5.5, 6, that's good. You don't necessarily want your white blood cells to be too high normal, because if you're not sick and you have these high normal white blood cells, that usually points to some kind of inflammation because the immune system's on point there. And yours is perfect too at 4. What is it, 4.1?
Yeah, speaking of this patient, I just talked to her last week, and she commented on our YouTube channel. A little embarrassing, whatever, because she actually watched it. But hers, so looking at mine, so yours is 5.9, mine's 4.1. So both of ours are at the bottom end. Hers is always chronically on the higher end, or even a slightly bit elevated. She's even went to a hematologist, and they didn't really give her many answers. We're still trying to figure out now. For hers, her lymphocytes and neutrophils are also a little elevated as well. So definitely something going on there as why her numbers are chronically on the high side of normal. She doesn't feel bad. She doesn't have any apparent infections, but like you said, some indicator that there's some inflammation going on, just in general. She doesn't have any blood cancers, no leukemia, no lymphoma, nothing like that, but just her high normal is up to, this reference range goes up to 10.8. She's always sits like 7 to 15 somewhere is where she goes.
Well, these are based on, bell curves of huge populations. Not everybody's in the bell curve. That might be her normal. But if you do see it move around from 7 to 11, that would tell you there might be some little bit of an inflammatory process or some kind of immune reaction to something.
Yeah, sure. Well, without freaking anybody out, but she's a little nervous because mom had breast cancer. Mom also had the same thing with the elevated white blood cell count for a number of years. So she's trying to be proactive, and she's making sure that she's doing everything right so she doesn't get any surprises down the road. So hard to pinpoint why that would be when she feels relatively pretty good on a daily basis.
You could look at them seasonally. Sometimes I've done that with patients when I see we've always done it in the fall and it's running this level, then I'll say, oh, let's do it in the spring or let's do it in the winter to see if there might be a change there. But I mean, I don't want to worry her.
She didn't have any allergies, but it's, like I said, it's a little bit of trying to find a little bit of a needle in a haystack, because even though the number's elevated, it doesn't point to anything specifically. When you see the lymphocytes or neutrophils elevated, you might think, some kind of an infection, but she doesn't have
virus,
any, she doesn't have any sign of actual manifesting sign of infection of any sort. But now you also, so white blood cells, the red blood cell indices, hematocrit, hemoglobin, of course, you're not anemic in any way?
No, not anemic. Of course, I'm in menopause, but we can get into that later. But yeah, the red blood cells, then you have your hemoglobin, hematocrit, which is like the oxygen component, or that basically like the iron component that grabs the oxygen inside the red blood cells. So you don't want to have too low red blood cells. That means you're bleeding, but then you don't want to have too low hemoglobin and hematocrit. That means that your iron levels probably aren't good on your CBC. Then you have the mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, which is looking at the morphology of the red blood cell, which is nice because you don't want it to be too chubby, because if it's too big of red blood cells, that usually means like B12 deficiencies, maybe too many adult beverages, or if they're too small, that would mean maybe not, malnutrition or not enough good nutrients.
Or iron, if like you said,
iron.
if someone's bleeding.
Low iron. So mine looks really good. What's interesting in females, you want to make sure that our iron isn't too low, that we're not anemic, but a man, especially being on testosterone therapy, you want to make sure they don't have too high red blood cells, because being on testosterone therapy can actually increase the renin in your kidneys.
Erythropoietin.
And then the bone marrow, and then it raises up the total red blood cells and makes them sticky.
Yeah, so if you look on your husband's or your boyfriend's blood work, so your red blood cell count, your hematocrit, hemoglobin, when a man is on testosterone, it doesn't happen for women as much unless their dose is relatively high. But if a man's dose of testosterone is high enough, which most of the time it is, then those three numbers have a tendency to increase. That's when a doctor says their blood is thick. Mm-hmm. Is it really thick? Not exactly, but sort of, right? Sort of. Their testosterone is a very, as I mentioned, it's a stimulator of another hormone from the kidneys called erythropoietin, and it tells your bone marrow to make more red blood cells, and those numbers go up. It's a sort of a normal occurrence. If the numbers for men get to be too high, then all they have to do is just go donate some blood, and and the numbers come back down and they're fine.
Yours looks really good.
And
you never donate blood, even though we probably should, just as a nice community service.
Yeah, I'm an O negative too, so they probably would really.
And we're definitely going.
Really like my blood for sure. So most of the time, these things are going to check out to be fine. It's a good screening test more than anything. For women, I think it does matter. Just like you said, from those nutritional things, B12 or B vitamins, iron, you can tell a lot by a CBC just on those. And of course, men tracking those red blood cell numbers if they're on testosterone. Move on to the CMP.
Yep. And then, so the comprehensive metabolic panel, that's another really common one that your doctors will run for you. So that looks at the fasting glucose, and we were fasting that morning, because sometimes we don't always have everybody fast when we're checking for hormones, but we did go in fasting.
And sometimes we do that on purpose to see what their numbers are. If they go in non-fasting and their number's 180, versus 105, that's a big difference.
Yeah, so mine was good. My fasting glucose, you wanted under 100. I was at 73. You were at 90? That's perfect.
90. I'd like mine to be in the 80s. I think 90 is a little on the higher side. Yours has always been low, 73. I mean, it can't be any better than that.
I think it changes. You were the one that drove, and we were trying to find the place. So that can sometimes spike up your cortisol, which can pull that glucose up. You have a needle coming in at you, stabbing. That spikes up the cortisol.
You're not afraid of needles. I'm not afraid of needles.
I'm not afraid. That's why I was 73.
Yeah. Well, we're a little competitive, right? So you beat me there. Your number's better.
I don't think that's better.
Your number's better than mine.
It's the same.
I want a number.
Good.
I want a number in the 80s. So at least, but 90 and, when you're in the mid 90s and above, closer to 100, we've sort of, assume that that's sort of a normal number, but we actually should be kind of where you are, 85 and below as opposed to 85 and above.
Well, you don't want it too low, then that's showing a little bit of hypoglycemia. Like I have some people, it's at 65, 58, and I'm thinking that's a little too low.
Yeah, but that's also indicates some very particular, pathology when those numbers are too low like that, right? So I like my number lower. Yeah, okay, so. Now, the next thing for a CMP is going to be your kidney numbers. The main one there is looking at a creatinine level. diabetes and different things like that, that creatinine level starts to rise. You do not want that to happen. That's when your kidney function is starting to decrease. If it goes up too much in your EGFR, your estimated glomerular filtration rate, that's the big word for the day. If that number goes down too much, that's when someone is in kidney failure or approaching kidney failure. You want to be very, very cautious with your creatinine level. Those on both of ours look actually really good.
Yeah.
And I wouldn't expect you and I don't have any kidney issues or
blood pressure issues. Sometimes hypertension not taken care of for years and years can drop those numbers or just alter the kidney numbers.
Electrolytes, those look fine. Wouldn't expect there to be any issues. Protein, albumin, total protein, albumin, those are fine for both of us.
So the electrolytes are sodium, potassium, chloride, and carbon dioxide. And then when you're looking at for like the albumin and globulin, that's secreted from the liver, so it kind of keeps your blood sort of so it's not like water, like bleh. It's like got a little viscosity to it, so you don't want to have those levels off. And then we have the AST and ALT, which are really cool to look at. Those are the liver enzymes.
Yeah, we see those elevated quite often. My alkaline phosphatase is actually low, which I don't consider that to be a bad thing. I would rather have that number. When it's low, you don't really worry about it. When it's elevated, it could be a whole bunch of things. When it's elevated, it could be nothing or it could be something. That's one of those numbers that's sort of really unspecific. But 42 reference range goes down to 44. I'm actually pretty happy with that.
Oh, you mean for the ALT and AST?
No,
you mean
for
the
my ALK phos is low. Your ALK phos is normal.
Yeah. Mm-hmm.
AST and ALT, we see those elevated quite often. That can be anything from fatty liver to too much alcohol to too much fructose or high fructose corn syrup. Yeah, even medications. SSRIs, statin drugs will raise those numbers. We see those over the years. We've seen a lot of people.
Obesity. I've seen people, they don't drink it all, but they actually, have some obesity issues and their liver enzymes are elevated.
Yeah, or insulin resistance, which then leads to the fatty liver, and those things are all connected, and those AST numbers will start to go up. If you see them elevated on a couple of subsequent lab tests, then usually the normal thing would be to go in and have an ultrasound, a liver ultrasound. That's the way you diagnose fatty liver, is you have a liver ultrasound, and the radiologist, they'll confirm if there's any presence of fatty liver there.
If someone's really sick, when I've had some people with the flu, this was a bad year for the flu and for viruses, I did sometimes catch them where their white blood cells were elevated, the neutrophils are elevated, and the liver enzymes, because, the liver works hard when you're sick.
Yeah. So those enzymes, the AST and ALT, are enzymes that are supposed to be inside of your liver cells. So when they show up in higher concentrations in your blood, technically that sort of means that those cells are dying at a little bit of a faster rate. So the concentration of those enzymes goes up. We don't want that to happen. Now, when they're in the double digits, so mine's 26 and 29 respectively. What are yours?
13 and 14.
Yeah, right. So those are really good numbers. Yours are a little bit better than mine by quite a bit. Still fine. But when those numbers are elevated but still in the double digits, that often means fatty liver. When they're in the really high triple digits, then you're thinking some kind of hepatitis. And that's where usually most doctors won't test them or do an ultrasound if they're elevated under 100. Reference range goes up to 40 and 44. Okay, so let's say a number I see a lot is like 69 or something. 72, 57. It's elevated, but it's just barely elevated. Usually a doctor's just going to do a watch and wait. Okay. Now, you and I have done that over the years. We'll do a watch and wait as well. If it comes back a second or a third time, that's when we might consider doing an ultrasound. If it doesn't come back down.
We do a lot of liver herbs, liver health, things to help with the liver, and then retesting it.
Yeah, I'm saying if it doesn't improve or it continues to go up. So cholesterol panel, what was your total?
193.
Okay, so this is where ours vary quite a bit. My total is 273. Okay, that's a pretty good number.
I don't have any family. I don't think I have any family genetics with high cholesterol. I think both my parents have some high cholesterol, but it's not genetic.
Yeah, right. So yours is pretty good. I mean, you don't have any, like you said, strong family history. It doesn't have to be under 200. You
have strong family history.
My dad, yeah,
Very strong family
history. My dad
history.
had a lot of heart attacks.
Lots of cholesterol.
But the total cholesterol, as we're learning, the total cholesterol really doesn't mean too much. Now, the two numbers that I think that mean the most, what is your triglyceride numbers?
52.
Okay, so mine's 58. Okay, what is your HDL?
So the high density lipoproteins, the higher the better. That's the good beneficial cholesterol is at 72.
Okay, so those two numbers are 52 and 72. And then my number is triglycerides is 58. My HDL is 60.
Oh, that's good for a fella.
Yeah, so you very rarely, so grab your calculator there for a second.
Grabbing it.
So very rarely do you see men, Caucasian white men, 50 and above, that'll have a triglyceride level lower than their HDL level. Okay, that's very unusual. I'm very proud of that because that's a sign of relatively pretty good metabolic health. When you have a low triglyceride and a high HDL like yours, your ratio is actually, once you do the math, so you're 52, your triglycerides divided by 72.
All right, so triglycerides divided by HDLs is 0.722.
Yeah, that's great. We want that ratio, triglycerides divided by HDL, you want that ratio to be less than 1.5.
Oh, okay.
Okay, so you're basically less than half of the ratio. That's pretty good. So now do mine, 58 triglycerides and divided by 60 HDL.
0.96666.
Okay, so it's still below, still you beat me on that one, but still below 1.5. That tells you, just those two numbers alone, a lot of doctors don't run insulin levels. That number, that ratio, the triglyceride number for sure, and that ratio tells you quite a bit about where someone's metabolic health is.
So if somebody had a triglyceride of, let's say, what's a common one, like 185?
Triglycerides, I see a lot, the hundreds, 120, 125.
150.
150 is where it's abnormal.
So let's say 150 divided by, and you see a lot of people with maybe their HDLs around 50, especially for fellas. A lot of times I've seen men, their
45.
HDLs, 35. So we'll say divided by 40. So that would be 3.75. Yeah. So that would point
you're
to...
You're sort of heading in the wrong direction there. That tells you a tremendous, just those two numbers tell you if you didn't do anything else on this, you just had a lipid panel, the total means nothing. At least that's the new kind of thought and idea that total cholesterol does not translate to cardiovascular events. Like it doesn't lead to strokes and heart attacks just because the total's high. A cardiologist will tell me I need to be on a statin drug immediately, but they don't pay attention or don't pay enough attention to the triglyceride HDL ratio. Triglycerides is diet. The more processed food, the higher your triglycerides, the higher your insulin, the higher your insulin, the higher your triglycerides. The HDL, that one's a little bit more challenging.
Or
right?
Exercise. Like
exercise.
Runners, hikers, we do a lot of walking. That does help raise up your HDLs a lot.
Yeah, that one's maybe more genetically determined, but you're right. Being sedentary, the number's going to go down. When someone's metabolically unhealthy, their triglycerides go up and the HDL goes down. The total will go up, the LDL will go up, but the HDL goes down. That's what you actually don't want. So as a 50-year-old Caucasian male, when you see the triglycerides lower than the HDL, so check all your husband's blood work. That is, or your boyfriend's. That's a very good sign. Yours is, obviously a little better than mine, but still, HDL higher than triglycerides is good as that's what you're shooting for.
Yeah, and maybe we love to hear from listeners. If you wanted us to go into a little bit more about cholesterol and how we're going to lower your LDL cholesterol naturally without statins, we could do that on a different podcast. And we're going to redo this blood work too, so we can compare it.
Yeah. So my LDL. So what's your LDL?
111, so it's actually considered high.
Yeah,
but sure. I wouldn't call that high. Honestly, You don't want too low of cholesterol. I think right around 111 is just perfect.
Yeah, I think this is where a lot of the controversy is coming from is LDL. Again, cardiologists think that if your LDL is low, you're fine. My LDL is 204, which is not a good number.
We'll be retesting that at some point in the near future.
We're gonna have to work on that one a little bit. I'm not proud of that number. It's a little bit too high. But again, that ratio, that's becoming sort of the new idea, and the total of the LDL, those other things don't. There's there's research to say that LDL is attributing to atherosclerosis, and there's other newer research to say that a higher LDL is good for longevity. So which one is it? If LDL is good for longevity, then I'm going to live a long time.
There you go.
Right. Yeah. So we'll see how that plays out. Now we're getting into hormones. Now we're getting into some of the hormones.
Now we're going to get into the hormones.
Which you have your pregnenolone. So your pregnenolone is actually really good.
Yeah. So pregnenolone is a hormone that comes from the adrenal glands. We do make a little bit in our brain and our spinal cord, and I think a little bit also with the liver. But it's really good for memory, for short-term memory, for learning, for cognitive. So a lot of times, the reason mine is 128, which I like to see at 80 and above, is because I take pregnenolone. So that's probably why it's 128.
Yeah.
I take 30 milligrams of pregnenolone.
Yeah, my pregnenolone is less than 10, so I don't have any pregnenolone.
It's not even found in the bloodstream.
Yeah, no, I have like none. Now, I would have expected, to be honest, that, because you're sort of like the anxious type and a little bit of a worrier, and I'm not, that I would expect that our numbers would have been kind of the opposite. But that's a supplemented number.
Yeah. If I wasn't taking the pregnenolone, it'd probably be a lot lower. For you, I mean, you think about, well, if the pregnenolone's low, what does that mean? Does that mean that you're stressed out, that you have adrenal fatigue, adrenal dysfunction? What's that mean?
Yeah, I mean, that's a good question. I was a little surprised by that my number is as low as it is. But, you're 50, you get a little tired. We're running a business. There's a lot of things going on there. I would expect. Now, as a result of that, I'm supplementing with it just to see, what when we do another round of blood work, what that number is going to go up.
Do you notice with supplementation, do you notice like if your mental energy is better, you feel clearer, you're sharper?
Yeah. I'm taking a little bit of a higher dose than what a woman would take. I'm taking 50 milligrams. So we'll see how that translates. Something like that is going to be subtle, but you're giving the body sort of the building blocks for all those other steroid hormones. Everything else sort of branches off of that. DHEA, testosterone, even cortisol for that matter, is being created by how much pregnenolone's there. So having none, that means your body's going to have a hard time making other hormones. So we want to prop that number up as much as we can. Now let's skip ahead.
Wait, before we leave pregnenolone, like you said, you're taking 50 milligrams. I'm taking 30. I've actually bumped that down a little bit because I do feel like women don't need as much, just body size, like 10 to 20 milligrams, 30 milligrams. I have some women on higher than that, but it is good to test. So at 128, that's great. I kind of backed it down a little bit.
If you're at 30 and I'm taking 50, I should probably bump mine up to 100.
Well, I bumped it down to 20. So, and then I'll test myself on that.
Yeah. But if you're at 30, but now you say you went down.
50 is good. I don't think you need to go higher than that.
Well, it is like it's not even registering there. I got a single digit number. I got to do better than that one.
But then, there's other things besides taking pregnenolone, like the walking, sleeping.
Oh, sure. Yeah. Now let's compare that. So we do these two on purpose. So pregnenolone, mine was not so good. My DHEA was 166. What was your DHEA?
253.
Yeah. So your DHEA is better than mine. Mine should be 253.
I wouldn't say it's better. Mine's actually high, but I think that's my normal.
Yeah.
Like I said, everybody's different. They go by these bell curves. So DHEA for a woman that's, 51? I'm 50. I'm going to be 52, but 51 has 41.2 to 243.7. They always change these reference ranges. So if I was 25 getting this done, it'd be a completely different reference range, and I'd be in normal range.
Yeah, I think mine here, the reference range for me is 71 to 375.
That's huge.
But I should still be closer to the 375.
But I know
you got a number like I should have, and I have a number like you should have.
I know I naturally run a little higher. Of course, pregnenolone can convert into DHEA with some people, not with everybody. But this is my normal. That kind of I remember when I did my mom's blood work. What is she, 75, 76 now? I think she must have been
she's 76.
76. So I think when she was like in her 60s, we ran it. And she does run higher in her testosterone and her DHEA, which you'll see that's what I run too.
And then we said on the last one, we were talking about hair loss, that you heard somewhere, maybe it was the Okinawan diet book or something, that Okinawans are sort of, I wouldn't say prone, but are predisposed to having higher androgen levels.
Yeah, the testosterone and the DHEA. So that makes sense. My mom's from Okinawa. I'm half Okinawan. Sure. So I think that's normal for me. Now, if that DHEA wasn't normal for me, I'd probably be breaking out and having some androgen issues, and I don't have any of those.
That's how you sort of tell, right? If you've got a high normal or elevated DHEA and or testosterone and you're breaking out, as a female, right? That's sort of like along that PCOS line. They call that, when women's having hair growth, they call that hirsutism, or like I said, blemishes, right? That's a very common thing. Now testosterone, my testosterone was 606.
Well, wait, can we back up to the DHEA real quick? Okay. So do you think yours should be higher? So the fact that because DHEA comes from the adrenal glands, and so DHEA and then your pregnenolone's low, so you must have adrenal insufficiency. Are you tired? Are you okay?
Well, I mean, that's why we
stressed out.
That's why we test. That's why we test those, the pregnenolone and the DHEA specifically. It gives us doing cortisol through blood work isn't necessarily an ideal way to test it. So we infer what someone's cortisol, situation is by looking at those two numbers. So for me, yeah, you would assume, because my DHEA should be at least in the 200s, at least around 250 at least, and my pregnenolone is non-existent. So, those numbers could be a little bit better, to say the least.
I'll treat you with kid gloves.
Okay. Yeah. Thanks. Okay. So So move on to what's your testosterone?
43. So they have this huge reference range. What is it? 4 to 50 for testosterone for a female. I think Quest has theirs like 2 to 45. Like all these labs have these huge reference range. Like why is 4 normal or is 50 normal? Like that's just such a big reference range. But I would say most women, just with us having treated a lot of women over the years, is most women run around 20. Like that's a
20. I would say 15 to 25.
Average number.
20,
so mine, like I said, mine's a little higher just because of my genetics. I'm at 43.
Yeah, I see a lot of numbers, especially those women that are entering perimenopause. Now you see it sort of both. You see them below 10, right, in the single digits, or you see them kind of high normal, like, it's in the upper 30s or something. But honestly, I think it can kind of span. But statistically speaking, most of them, I would say you're right, 20 is probably a very common number, 15 to 25-ish. Mine's 606. Every man sort of.
Oh, for your testosterone.
Every man wants to have as high a number as possible. At least it was above 500. I'm pretty good about that. But see, now here's the thing. If I supplement it with a little bit of pregnenolone and some DHEA, would that boost up my testosterone numbers?
Well, you're doing testosterone replacement, but you're doing it as a rhythmic dosing, so that testosterone doses change every like 5 days. Do you remember what? Because us women cycle when you're menstruating every 28 days. Men actually have a cycle as well. Do you know what day you were on for your testosterone?
I'd have to go back. I don't think I pay.
Actually, I know. You and I sync up. I was actually on day 3 of my cycle because I do a rhythmic dosing progesterone, estrogen as my hormone replacement therapy right now. So I remember I was on day 3.
Yeah,
so you must have been on day 3.
I would have been on day 3. So
that would have been a little. So this is probably a little bit lower.
Yeah. That's the lowest.
So
day 3 for men's rhythmic dosing is the lowest of the month. So it starts on day 1. My day 1 is your day 1. Mm-hmm. So I follow you. So you start the protocol. I overlap on your schedule. So my first 4 days is the lowest, and it starts to rise up to day 20. Actually, you stop on day 14. That's
right.
That's right around when you would ovulate. So you stop right about there.
Which I'm not.
Yeah, right. And there's a little surge from day 16 to 20 as far as the dosing. So ideally, if I wanted to really peak that number out, I'm actually really happy with that number because I did not put on any testosterone cream that morning, and I was on day 3. So my baseline low number for the month being a 606, that means if I did it on let's say day 18, so day 16 to 20 for the dosing schedule that I'm on is the highest, I would assume that that's going to be anywhere from 150 to 300 points higher, give or take. So I might be closer to 750 to 900 on that 4-day window. Then day 20, then it starts to come back down until your cycle starts. When your cycle starts, then we both start back over on day 1. So that's just one way where couples sort of go back and forth through rhythmic dosing. Women start it, and then men sort of overlay. So that way, at least hormonally, there's some synergy there, as opposed to men starting a schedule and then you starting your own schedule, and there's no synergy at all. They're just kind of opposite. So we've done that for years, and it seems to for couples.
Well,
it seems
not for
to
years, because I just
no, you and I haven't. I was talking with patients.
Oh, yes,
anyways.
exactly.
With patients. You and I, you just started that. I adjusted by following your schedule. So I'm actually like you said, I didn't realize it was day 3, but for day 3, I'm actually happy with that number. I'm a little bit embarrassed on my pregnenolone, and my DHA should be higher. But 606 on day 3 is actually pretty good.
We'll work on your adrenals.
Yeah, right. All right, now let's do one more hormone. Okay. So you're on day 3. This is where estradiol for you is important. Mm-hmm. Estradiol for me is sort of important because I'm supplementing with testosterone. So most men are not, unless they're really, metabolically unhealthy, like a full-blown, like a really bad uncontrolled diabetic, their estrogen levels don't really shoot up that much.
You'd be surprised. I have some men that are not diabetic and they're not insulin resistant, but their testosterone converts over to estrogen a little too easily that we have to block it.
It'll be like, are they on testosterone? Oh, they're on testosterone.
Yeah. If they're not on testosterone, you're right.
I meant just in general.
Without being on therapy.
Man, there's all this talk about, men develop man boobs and they're going through menopause and all these things. Most men are not going to start just greatly producing a bunch of estrogen until they start using testosterone.
Then you just have to watch it.
Yeah, that's called aromatization. When you go from testosterone too much, your body will aromatize that into estrogen. So because I'm using testosterone, I tested it. Mine was 40.6. The reference range goes up to 42. Yeah. So I'd like to see it in the mid 30s, preferably below 30. But once you're on testosterone, it's a little challenging to get it below 30.
Some chrysin, some DIM, 3-indole
Yeah, some
carbinol.
DIM. This is one application where men could use DIM to lower that number. Certainly chrysin's been around for a long time. That's sort of like a prescription called Arimidex, sort of does the same thing. It blocks an enzyme called 5-alpha reductase. So it blocks the conversion of testosterone into estrogen. Men don't usually go that way on their own. Like I said, usually it has to be in the presence of testosterone. So now I'm really curious on day 3. So her doing rhythmic dosing, the timing of her estradiol sort of matters. So what was your number?
I would say it was a little bit on the higher end. Now I'm doing rhythmic dosing. If you're doing hormone replacement and it's static dosing where it's the same dose every day, you do not want to have the levels that I have because that wouldn't be safe. It'd be way too high.
No.
Because static dosing, you have to do totally different than you do rhythmic dosing. But with me doing the rhythmic dosing, I was on day 3. My estradiol was 161.
That's. I still think that's a pretty good number.
I mean, it's not too low. It's not too low. So you also have follicle stimulating hormone and a luteinizing hormone that you do for women. You don't necessarily have to do that for men. Those are signals from the brain that monitor overall basically hormone levels. So my FSH is at 21.7, which isn't bad for doing the rhythmic dosing. Now somebody that's on a static dose, like taking a biased transdermal cream, 21.7 for an FSH is way too low.
Way too low?
Yeah, that would mean that their estradiol level is too
low.
high. Because it works inversely proportional. So the higher the FSH, the lower the estradiol. So when someone's going through menopause and that estradiol starts to drop, you'll see the FSH go up. And then when you raise up that estradiol, as in my case, you see that FSH go down. So even though, and like my luteinizing hormone is 9.1. So somebody, if they didn't know that I wasn't taking rhythmic dosing and they looked at my levels, they'd say, oh, you're not in menopause.
You're in perimenopause.
Yeah, but I'm not because I'm in menopause, but I'm taking, my rhythmic dosing for the hormones.
So the dosing, the dosing you're taking is lowering your FSH. Yeah. And you want that number to be, closer to 10, wouldn't you? Ideally?
I think that's good. No, I think this level is good. It's kind of like, I'm doing the bioidentical hormones. It's sort of like, which I know you think it's cheesy to say, it's like, I'm being my own ovary. So instead of having my ovaries produce the hormone because they have since retired, they're in Hawaii, they're having a good time.
Why did you say it's cheesy?
It sounds weird. I'm being my own ovary and, supplying the same exact hormones. They're bioidentical. It looks just like self. It's just not coming from the ovaries because they have done their good work for their lifetime and they're on their way.
Yeah. So in contrast, if you're doing static dosing, now the patch will lower the FSH almost too much sometimes. Transdermal cream like a bias, that won't really have much of an impact on FSH too much. Have you seen a lot of fluctuation with biased?
Yeah, a little bit, not too much. The luteinizing hormone is more connected to the androgens like testosterone, progesterone. It's also connected to progesterone. So that's probably why my luteinizing hormone's a little bit lower, is because I do have those higher levels of androgens for that's just my genetics.
I think your estradiol level of 161 is pretty good, though.
I think it's good. Mm-hmm.
Now, on day 12, you did this on day 3, so you're roughly 9 days early. As you are continuing on your rhythmic dosing schedule, it peaks out on day 12. So ideally, when we send a woman into the lab, we want to see that number on day 12. We're shooting for roughly, now the subjective response of the woman is always what matters, but we're shooting for a number between 3 to 350. Even 200 to 350 is kind of the range.
On day 12, we also like to have them go in on day 21, which is when the progesterone peaks. So you can see, so for, on here, my progesterone is 0 because I'm not taking progesterone, on day 3, but on day 21, when that progesterone is the highest, that's a good time to test as well. What would you envision someone's estradiol on day 21?
Kind of like where yours is now, right? So let's say if you're shooting for 350 to 300 on day 12, you'd want to see it, 250 or below on day 21. I mean, that's not a lot of time. You're only talking 10 days difference, 9 days difference, but we'll put up, one of these days we'll put up a picture of the female cycle and you can see, or you can look it up on Google or online, you'll see the different peaks. We're trying to replicate those peaks with rhythmic dosing, which is why we feel it makes, when you're trying to replicate that it's the rise and fall of those hormones that makes women feel the best.
And yes, being on the rhythmic dosing, because I have a uterus, I get a period. I do. Yeah. I know a lot of women are like, I don't want to have a period, but they're not bad periods. It's supposed to have the hormones balanced. So it's just a normal period, but that's part of the safety effect. And when you're doing rhythmic dosing and you're changing these hormones, you do want that lining to shed every month so that it's not
like you said earlier, you wouldn't want to be on the patch or biased or anything or a troche or anything like that and have a number of 161. Either you're going to start bleeding at some point, or worst case scenario, there's no bleeding at all, but that lining will continue to grow. And that's it's sort of a dangerous proposition. That's why for some women, it's probably a good idea to think about doing a transvaginal ultrasound. Pap smears, and we talked about that on a few episodes ago, Pap smears don't really tell you a lot of information. I would rather have a woman go in for an annual transvaginal ultrasound and skip the Pap smear. Mm-hmm. Now, maybe do both. Those are two different procedures for the most part. But I think especially if she's on hormone replacement, the transvaginal ultrasound is going to give you a lot more information, where the Pap smear is just screening you for uterine cancer or for cervical cancer. That's not,
the cervix.
For a woman in her 50s, that's not really much of a concern. That's not really telling you very much. Where the transvaginal ultrasound, especially if she's on hormones, that could catch a problem before it becomes a problem.
And then for you, now the prostate-specific antigen, the PSA, it's not the be-all, end-all you're going to hang your hat on when you're looking at something going on with the prostate, but you certainly don't want that number too high. And yours is perfect, under 1. 0.7 is great.
Testosterone replacement, so men that are using, whether it's transdermal cream like I am or an injectable, in the beginning stages of using testosterone, that PSA can go up. It doesn't always go up, but it rises in the first 9 to 18 months. Now, the men that I manage with testosterone, we watch it because their primary care doctor or their urologist is going to pay attention to it. So we want to see if it goes up with the testosterone, and then eventually they're on it long enough, then the number comes back down. Or if they stop it, the number comes down. But them being on testosterone and raising the PSA, as long as you know that's the testosterone raising the PSA, that's not really a big deal. It'd be a much more of a concern if a guy's 60, 62, 63 on nothing and his PSA goes up from 2 to 4, that might be a little bit of a concern. Unless if he actually has prostate symptoms, then he's probably just got BPH, which is also going to raise the number. That doesn't, just because he's got symptoms, he doesn't pee well, he's got urgency, that kind of stuff. He just got a swollen prostate. That doesn't mean he's got cancer.
Yeah, or non-cystitic, infectious prostatitis, so that's swollen, or like you said, the BPH, that's where the cells grow and it just gets bigger.
Yeah, so I mean, the PSA has been, prostate-specific antigen has been done for years and years and years, ever since we've been in practice, and 20, 30 years before that. But it's not a very good screening test because you get a lot of false positives and a lot of false negatives. So if the number goes up, then a doctor's going to refer someone to a urologist to do a prostate biopsy. No man wants to have a prostate biopsy. Now, if you find cancer, that's great, but the accuracy of that process of a high PSA biopsy turning into cancer is relatively pretty low. I don't know the numbers on that. Do you know any numbers about that? Like the accuracy? I should know those numbers, and off the top of my head, I don't, but it's just not a very great screening test. Now, the rise of the number in a 6-month period, like I said, if it goes from 2 to 4 or 3.5 to 6, that's a little bit more of an issue. A higher increase in a shorter amount of time, and especially if there's a family history. But Dr. Ben Bickman, he's my little research man crush I have. He talks in his book. He talks about prostate issues being an insulin-resistant problem. 50-year-old Caucasian male or 50-plus Caucasian male, they're all insulin resistant. That's what's driving some of their prostate issues, not because they're on testosterone.
Well, you're not insulin resistant. Your insulin's really nice and low.
Yeah, well, and my PSA is good, is my point. Now, we got to talk about your vitamin D.
My vitamin D is way too high. I was taking a whole bunch of it. Cold and flu season was awful this year. I was just like taking those drops.
I guess, yeah.
It's not terrible. I mean, it was at 122. I like to see it between 55 and maybe up to 80. Because when you get over 80, it's too easy to flip over to. So I know it was too high, so I backed off on it. 60
to 80, I think, is a good range. Mine was at 47. I don't probably do it as religiously. You do it every day, don't you? And with a number like that, you must have been doing
extra.
Oh, you're doing when you did it. You were doing a whole bunch.
I was doing a little bit extra. Just
So I prefer the drops. You're doing the drops.
I didn't get the flu this year, by the way. So.
Yeah, you were doing the drops, right?
Yeah,
I prefer the drops. The vitamin D K2 drops. You got to be a little careful. It's 1,000 IUs per drop. 5 drops, 5,000 IUs. Most of the time, that's usually pretty good. But I
was doing more.
You must have been getting a little aggressive there.
I was doing a little more.
Yeah, I don't do it every day. I probably do it, a few times a week. My number could be a little higher. I'm only at 47, but at least it's closer to 50 than it is to 20. C-reactive protein, I did that. Mine was 1.27. Do you have a C-reactive protein?
I didn't do the CRP. I'll do it next time. I mean,
I don't like that number. I like my number, below 1, but it's less than 1.5. Right, for reference range is 0 to 3. I certainly have a family history. Homocysteine, we didn't do that for you. No. Again, that's more of a Caucasian,
because of your family history.
Male Caucasian, sort of male, more of a male number. Mine was 10.2. Again, a little bit on the high side. So I've gotten more consistent with my B12 folate, trimethylglycine supplementation. That number, for me, I'd rather see it around 8.5 or less. Preferably 7.5 or less. In some ways, sort of the lower the number. And I'm also compound heterozygous for MTHFR. So I already know that my the dog is right there.
She's being a little needy,
getting attention. One of the comments on one of our previous episodes called her the producer. She's looking for some attention. So my homocysteine, I don't like it for men when it's in the double digits. So mine should be, at least 2.5 to 3 points lower than that. And it's really interesting. We use from Orthomolecular, we use methyl CPG, and that number goes right down with that. So I wasn't as consistent up to this blood test as I should have been. Okay, so what do we got left? GGT. GGT is another liver enzyme, so similar but more sensitive, sort of, to the AST and ALT. What was your number?
10.
Okay, 10. Mine was 12.
That's good.
Yeah,
very. No liver.
Yeah, that's
acute liver inflammation or damage is the GGT.
Just a little note: when people drink a little too much wine or a little too much alcohol, that number is a little sensitive to alcohol consumption. So that number has a tendency to climb with alcohol. 0.65, or excuse me, 0 to 65 is the reference range. Like I said,
for yours, maybe yours is different for men. Mine says 0 to 60.
Oh, that's interesting.
I know, isn't that?
Yeah. Well, I guess male, female, that's fine. But that's pretty darn close. But ours are both very low normal. Uric acid, so that is the metabolite or the metabolic compound that is synonymous with gout. So as your uric acid goes up, you have a predisposition to gout. Gout is not necessarily from people eating too much protein per se. It's more of a liver blood sugar problem. And then as a result of the foods we eat, now our uric acid goes up, and then it can crystallize and end up in the big toe and causing lots of pain. Reference range 3.8 to 8.4. Mine was right in the middle at 5.1. You didn't do a uric acid, did you?
No.
Yeah. Gout is a male problem. Gallstones and gallbladder problems are a female problem.
I've seen a few women with
but it's
gout
very,
with high uric
very
acid.
rare.
I think there's, isn't it like on the like the X chromosome or something, so that's why men with XY are more prone to it, but women with XX, that has to come from
there's
sides.
exceptions to every rule, but gout is predominantly...
Chuck's got gout.
Yeah, he's a man.
My dad.
He's a man. Predominantly a male problem, where gallstones and gallbladder problems are predominantly a female problem. But at least in my opinion, gallstones and gout sort of are the same problem, of what's happening in the liver.
And then we did a SED rate, a sedimentation rate. That's looking at another factor of inflammation, but it's more vague. Kind of looks all over. Like if I had a cold, my SED rate would be up. If I had osteoarthritis, would be up.
Maybe not actual
like
cold,
a terrible flu or something.
Yeah.
If I sprained my ankle, SED rate could go up. So it's just kind of looking at general inflammation. But I like to look at it because it gives me an idea.
It's just another marker of inflammation, just to see if anything's going on. Now, insulin, I think insulin is.
And ours is yours a 2? Mine's a 2.
2, yeah.
I've never seen less than a 2. I've never seen a 0 or 1. So 2 is good. I've seen 4s and 5s and 9s and 12s.
And we've seen a lot of elevated ones too. You'll see elevated ones like with rheumatoid arthritis, lupus, all the mixed connective tissue autoimmune diseases. Those numbers will start to go up. Now, insulin, this one I think is probably for most part is really important for everyone. I'm very pleased. My insulin was 1.7. What was yours?
1.1.
Yeah, almost to the point where they just seem
like, really?
They seem abnormally too low. Like I don't trust
too good to be true.
I don't trust those numbers very much because it just seems a little odd. Now we do a lot of walking. Our diet is not perfect but pretty good. I would expect the number to still be still below 7.
Under 9, yeah.
Still below 7, but 1.7 makes me question a little bit because we see a lot of numbers and you don't really see a 1.7 very much.
I see a few people with it low. Definitely, it's a petite females.
Well, of course, like I said, there's exceptions to every rule, but it's still very uncommon. It's still uncommon to see it that low. How many times do you see it? Like twice?
I can name a few times I've seen because I run fasting insulins, but a lot of times I end up running them on people that I know it's going to be elevated so we can get them to make a change.
Yeah, right. Yeah. You do not want that number to be in the double digits. Now, we were talking about triglycerides earlier. Fasting insulin and triglycerides, those two numbers are sort of go hand in hand. So the higher your fasting insulin, the higher your triglycerides. And most doctors will not run an insulin, so that's how you can infer where your insulin status is by how high your triglycerides are. So that's why, and when someone becomes insulin resistant, their triglycerides go up and their HDL goes down. That's why that ratio less than 1.5, mine was 0.96, yours was 0.72. That's why that ratio is, it translates into if you're insulin resistant or not.
Which will eventually become diabetic.
That will lead to diabetes, heart disease, Alzheimer's, and cancer. All the things we don't want are related to someone's insulin status.
Remember when we checked my dad's insulin level like 100 years ago? It was before he had diabetes.
It was 46.5.
I've ever seen.
Yeah. And then it still took another couple of years before he got diagnosed as a diabetic because his blood sugar was still normal.
His blood sugar was like 98,
97. And he sort of questioned it. Well, my blood sugar's normal, but
until it wasn't.
Until it wasn't, yeah. And it hasn't been normal since. But that's why you should be looking at insulin and look at glucose too. But that's why you can't just look at glucose because there's a problem below the surface that most conventionally minded physicians are not looking at. Even diabetics, they should be testing their insulin levels. They're not even testing them for diabetics. Okay, so I'm proud of
type 2.
Yeah,
diabetes.
I'm proud of both of our numbers. Our numbers are pretty good. I think that's it. I don't think we have anything else.
No.
Really, the only thing
my thyroid was way too high, but we're changing the dose because did a TSH, free T3, and free T4. And my thyroid's just a little high, so we just have to change the dose.
Yeah. You've been on that dose for a little while, so I think it's time to adjust it. I think that was kind of a down and dirty, some things that we typically like to look at. There's a lot of other tests that a lot of other doctors do. We try to keep it, we do a lot of cash labs for people. So we try to do what we need to see in order to make clinical decisions, what we want to see that sort of tracks someone over time, metabolically, hormonally. We don't do everything out there. We try to keep it as efficient as we possibly can. What's your thought about that?
No, I love being able to do the cash labs with patients because you don't even have to put their real name on there. Like this is just all labs. You can do it incognito. You can do a fake name if you want. So it's kind of a nice way to, if you are billing it to your insurance, it shows up somewhere. Now they say you can't, they don't change your rates or whatever if you're your
Well, yeah.
pre-existing conditions. But,
Yeah,
you know, somebody wants to apply for life insurance. I'm like, let's run the Monty here on its own and then, you know, go apply because we might need to change some of these levels.
Yeah.
Like yours, your cholesterol, if we were.
Yeah. So based on my numbers, my life insurance
rate wouldn't
premiums
be great.
would go up
Or it's not
because my total and LDL are too high. Whatever that means. Any other final comments? I think our numbers overall look pretty darn good. Yeah. So if you have any questions, write them in the comments below.
Oh, we have a newsletter coming out.
By the time this episode is out, we should have plugged that in the beginning.
No.
By the time this episode gets posted, you'll see the link down in bio for our newsletter. What's the name of the newsletter?
It's from Perimenopause.
Perimenopause. So it's all about hormones and a little bit about your journey and what's going on. I said the word journey.
I love the word journey.
Yeah. We were joking about that
And
earlier.
band too.
Yeah. So again, the link is in below. It'll take you to a website where you can sign up for it. It's going to come out twice a month. The first and third Tuesday of the month. So by the time you see this, it should already be, the first one should more than likely already be published, or it'll be just getting ready to be published. So if you're interested, the link is down below. And until next time, I'm Dr. Maki.
I'm Dr. Davidson.
Take care. Bye-bye.